Dr. Samin Sharma from Mumbai.
Yes.
Are you hearing us?
Yes.
Welcome back.
Yep, we can hear you very well. Thank you. Thank you. Myself, Dr. Mahajan, and our cath lab staff from Sion Hospital, ready to show you another case. And this is the coronary case. And Dr. Mahajan, you tell a little history.
He is a 58-year-old, known case of diabetes, chronic stable angina, had rest angina on 15th of July, some elevation of enzymes, and then he was diagnosed with a diagnosed as a non-ST elevation atrial myocardial infarction, and the coronary angio picture is in front of you.
Sure, we can play that. We can play it. Yeah. Now you see this here. There is a total occlusion of the LAD after the septal and the diagonal. You see the distal LAD fills by the collateral. It's a left dominant system. And this is what we have the plan. So we have engaged. Yep. It's a 6 French guide EBU. What's the guide?
EBU.
EBU. And we are going to the plan today is revascularize with the wire first, then decide which stent. But we actually have the miras available for this particular case. Now this is a run through wire. They'll die. I think it's in the septal now, yeah. Yeah, I may need a balloon support. Yeah, this is the LAD.
So in this case, you do not need a contralateral injection.
Yeah, this we do not know because I think it's more of an acute lesion. We take a picture now. Let's take a picture. Okay, let's get a balloon. We are 2.5 NC mosaic. Actually, both mosaic and NC mosaic are available in US also. They are distributed by the Cordis. It's a 2.5 balloon. And then we are ready with the IVUS also. We are actually looking for the OCT, but could not be made available. So we are going to use IVUS today. Yeah, go up. Negative. Slipped. We'll go a little slow. 2, 4, 6, 8. No, still moved. Yeah, length is what, 15?
Yes, 50.
Yeah, go up again.
4, 6,
8, 10, 12.
8, 10, 12.
Still a little distal, negative. So many times to remove, to eliminate this watermelon seed effect, you go a little slow. Again, 4, 6,
6,
no, 8, 10.
8, 10.
Again, moved. Okay. Yeah. Anyway, let's take one picture. Okay. Now, lesion actually involves, it's little after the diagonal.
3000 repairing तिकडून द्यायला
Yeah. Yeah. So I think if it's okay, the question is the lesion preparation
तू देऊन टाक.
before we put our miras, but it is a softer lesion. I think we can put a 2.75 29. What do you think?
Yes.
Yeah.
20.
And then we'll post dilate. You want to do IVUS first?
Huh?
Now?
Yes.
Okay. So we are going to do IVUS to assess the vessel size. Good. Now, how would they show IVUS?
Connected.
Yeah. Okay. Good. Okay, start. Now IOS is being shown there. Yep. Yeah. So this is the distal to the lesion. Yep. Yeah. Yeah, very little, no calcium. Yeah. This is the bookmark. This is the lesion. Little distal. Distal large plaque. The vessel size is about 3 millimeter. 1, 2, 3.
Yes.
Yeah. And this is the bookmark one. This is the lesion of that occlusion. Yep. Still there is a large residual plaque.
This is the proximal vessel.
Yeah. And then there is that is the diagonal and septal we saw.
So proximally it's larger than 3.
Even other, yeah, proximal is definitely much larger than 3. Now look at this. Even there is a lot of atheroma in the artery where it looks like angiographically okay. We can stop it. Okay, let's get a 2.75. So it will require a differential dilatation. Okay, let's
You
flush it.
consider 275 or 30?
So we're going to use again. Yeah, I think knowing that the distal is about 2. Let's go to the distal vessel. Looks like that was about 2.75. So we take a 2.75 and then we dilate proximally to 3.25 and so. Yeah. Okay, put a 2.75. Give us. Yeah. And proximal portion will dilate with the 3.5 maybe.
Meres.
Yeah.
2.75.
29.
29.
Yeah.
2.75, 29.
Yeah. So we have Meres 2.75, 29. Okay. Because that's a, could I use a smaller one? Show the
Kya
last
hai?
picture.
Okay.
Shorter length, I mean, shorter length. Minus. Yeah. Plus.
Bas.
Yeah. Plus. Plus. Good. Yeah. So we'll going to place this after the diagonal. Now, if we need anything proximally, we'll use a bigger one. We have 3.5 also. Yeah. Yeah. So this is a, take out the sheath and the wire, minimum touch with no touch technique. Good. Look for a 3O NC mosaic. No.
3.
Okay. Let's say little die. Yeah. Good. I think we are good. Good. That's what we wanted. So go slow.
2. 4. 6. 8. 10.
12.
12.
14.
Sorry, 14.
Yeah, just 14. Okay. Negative. Three marker on each side, right? Now you can see here the three marker on each side compared to our two markers of the absorbed.
3 balloon.
So it will require a little more dilatation. Yeah. And as you saw, the data were presented of the Miras 100, 6 months data showing very little late loss, 0.15 millimeter, and no event at 6 months, although one case between 6 months to 1 year. Now data is reaching about 2 years. We actually deployed in first 10 series few cases right from here.
Here.
And how has been your experience, Dr. Mahajan, on Miras, the cases which you've done? How many have come back, or besides just the angiographic follow-up?
All patients we had done a follow-up. 20
Yeah.
patients we had done. All
Yeah.
patients we had done a follow-up. I was OCT and 1 year HRCT.
Ah,
And the data is very promising.
very promising.
Very promising.
And no scaffold thrombosis.
No scaffold thrombosis.
Yeah, that is the biggest concern.
The
Yeah.
initial
Go.
10
Go. Initial 10?
initial 10 cases we continued with our dual antiplatelet protocol of aspirin and Plavix. And then remaining 10 patients
14,
we had done
14.
we had gone
16.
16.
Yeah. And remaining patients?
They were on Brilinta and aspirin.
Okay. Go up here.
10,
12,
12,
14, 16,
14, 16,
18,
18.
20. Now this is the 3O, and we have gone 20 millimeter. Yeah, there is still a dent in the center. But let's open this proximally. Just, yeah,
Okay.
now. Exactly at the dot.
14,
18, 20, 22,
18, 20,
22.
20.
Yeah, it expanded at 22. Yeah. Okay, we'll come back in the guide and then take a picture. No, let's take a picture. Yeah. The middle still remain a little dent. So let's go back. Here. Go up here.
14,
22, 22.
22.
Good. Negative. Okay. So now, question is, do we show the last picture? Play the last picture? No, let them play. Yeah. Next. Yeah. Yeah. I think the proximal we have to dilate further. Agreed? We need a 3.5, 8 millimeter proximal segment. High pressure. Right? Remember
think
the
we'll do
one it was, no, but
IVUS and then decide.
it was 3.5 proximally here.
We'll do IVUS and then we'll decide.
Still there is a dent.
There is some plaque prolapse or something like that. We'll do the IVUS
Okay.
and then
All right. So idea is Dr. Mahajan says let's do the IVUS, then decide exactly what is happening with the proximal segment.
Three 3.5 could be a bit larger for a 275 scaffold.
Yes. Good. Good. Okay, start. Yep. Okay. I was being shown, yeah.
start pullback.
Yep.
Started. Now we'll enter in the scaffold. हाँ इसके
Yep. Definitely opposed and fully expanded at this point. Yeah, here. Yeah, this is the one. We need to expand. This is the proximal area.
Dr. Sharma,
Yeah.
may I
Yeah.
ask questions?
We need
to you?
3.5. Yes.
May I ask question?
Yes. Absolutely.
So
3.5.
it seems to me that the
8 or
OCT,
12. Yes.
OCT will be better for assessment for expansion of BRS because they're more clearly visible
Yes.
scaffold slab. What do you think? What about that?
Absolutely.
OCT role?
Yeah. No, actually we wanted, but OCT is not available here today. But yes, that will give you more precise expansion, opposition, and see any edge dissections. Yes. It will be a better tool. So now we have a 3.58 high pressure for the proximal segment. Good. Okay. This is a 3.58 mosaic. Yeah. Let's go up here. Ten, 12, 14, 16, 18, 20. Actually, 3 markers gives us good negative. Gives a good landmark where our proximal should be. Go again. 12 here.
12
14. Good. Negative. Okay. Let's take a picture. Definitely has improved
Yeah, definitely, and geographically it's perfect.
the proximal segment. Yes. So I think if it's okay, we saw that it was the proximal segment only. We have post dilated with a 3.5 with a 20 atmosphere. We can just take the last picture with the nitroglycerin and we are done here. I don't think we need any additional. Take the wire out also. Yeah. Yeah. Sorry. Okay, let's give a nitro and we take a last picture now. Go to LAO. LAO cranial. Very good. If there is no question, we are done from here.
Perfect. Congratulations. Perfect result.
Okay. All right. Thank you. Thank you.
Thank you.
Thank you.